Good afternoon, everyone. Welcome to our webinar titled Do Fall Prevention Community Exercise Programs for Older Adults in Canada Meet Evidence-Based Recommendations? Facilitated by the Fall Prevention Community of Practice. My name is Shamiza Allard, and I am the Knowledge Coordinator at the Ontario Neurotrauma Foundation, also known as ONF. ONF sponsors the Fall Prevention Communities of Practice Loop and Loop Junior, along with the annual Fall Prevention Month campaign. So before we begin, I just wanted to cover just a few housekeeping items. So during the webinar, if you have any questions about the technology, please type them into the webinar chat box. My colleague Marguerite and I will be monitoring this. You can also email me at shamiza.allard@onf.org, and I've included my email in the chat box, and I'll work with you to resolve any of your any technical issues. So if you have any questions for our presenters about the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar. And just as a note, you'll only be able to view questions that you have asked and not questions posed by other participants. So the webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. And you can view previous webinar recordings. Simply head over to the webinar page on Loop and click Archived Webinars, and I've included a screenshot here for your reference. So I'd like to now introduce our presenters, Dr. Catherine Sibley and Alexi Toush. Dr. Sibley is an associate professor in community health sciences with a cross-appointment in rehabilitation sciences at the University of Manitoba. Alexi has a Master of Science in Community Health Sciences and is currently working as a research coordinator for Dr. Sibley. So for a complete bio of our presenters, please view the Zoom webinar invitation, or you can also check out Loop. So without further ado, please take it away, Alexi and Dr. Sibley. You may now share your screen.
Right. I'm just getting set up here. Oops, sorry, just having some issues changing this over. And there you go. Can you see my slides now?
Yep, we can.
Perfect. Okay. So, hi everyone. I first want to take this opportunity to thank the Loop community for having us speak today, and to thank everyone here for your interest in this topic, especially with the inauguration happening in the States. My name is Alexi Toush, and I'm currently a research coordinator working for Dr. Sibley at the University of Manitoba. Today, we are very excited to talk about this project, which was my master's thesis project with Dr. Sibley. For those who are interested in reading about the full project, the article has now been published by BMC Geriatrics and is open access to everyone. Before I begin, I would like to acknowledge that the University of Manitoba campuses are located on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Although this study was done before the novel coronavirus, we can't now think of these results and implications without thinking of COVID-19. Nationally, many provinces are in various stages of Code Red, with recommendations to only leave your house for the essentials. During Code Red, we've seen recreational facilities and community centers closed to the public, with their programs suspended. Social distancing and quarantine regulations also limit access to and opportunity for physical activity. This means that everyone needs to think of other ways of staying active, which can be quite a challenge. With this presentation, we hope to provide at least a bit of guidance on how programs can adapt to this new pandemic context. So we'll start with a review of the literature and rationale for this National Self-Report Survey study, and we'll present the objectives and methods, as well as discuss the major findings related to program characteristics and inclusion of evidence-based fall prevention recommendations. We'll then consider these findings in the context of the impact of the novel coronavirus on group-based exercise programs and considerations for online delivery. So although most of you probably know what a fall is and why we should care, I'm just going to do a brief overview here so we're all on the same page. So falls are commonly defined as unexpected events in which the participant comes to rest on the ground, floor, or lower level, and they are a major public health concern as they can lead to serious physical, psychological, and economic consequences. Although the incidence of falls is concerning, where approximately 20 to 30% of adults 65 years and older living in the community reporting experiencing a fall in the previous year, the consequences of these falls are even more concerning. Common consequences of falls include serious physical injuries, such as fractures or broken bones, and psychological consequences, such as fear of falling, anxiety, and depression. Falls also present a significant burden on the healthcare system. For example, falls that result in hospitalization can cost up to $30,000 Canadian per older adult, and falls that lead to hip fractures, which have even more detrimental effects, can cost up to $40,000 Canadian per older adult. Not only can the occurrence of a fall trigger a downward spiral of negative consequences, but a fall can also trigger the beginning of a vicious cycle in which the emotional, psychological, and physical consequences foster immobility and self-imposed physical activity restriction. These, in turn, can further increase the risk of experiencing yet another fall, starting the cycle all over again. As a global population ages at an unprecedented rate, the need for effective fall prevention initiatives becomes increasingly important. Here, I'll pass the presentation over to Dr. Sibley, who will talk about the current evidence in fall prevention.
Thanks very much, Alexi, and thanks for getting us off to a great start. So with that excellent overview of the problem of falls in Canada and around the world, this begs the question for us: how can we prevent falls? Well, there have been many interventions attempting to prevent falls targeting many different risk factors. Of these, we have extensive evidence for the role of exercise in fall prevention. Systematic reviews are important research designs because they examine the state of a body of literature. And in fall prevention, we have really good information from a 2017 systematic review that included over 283 randomized trials with over 150,000 older adult participants. And this review looked at all types of fall prevention and interventions in all older adult populations. And the conclusions of this review were that exercise is likely the most effective intervention to reduce falls and associated injuries in older adults. But many of you will also know that not all exercise is created equal. And this is not to say that just any exercise prevents falls. More detailed analyses have shown specifically that exercise that targets balance prevents falls in community-dwelling older adults. Another 2017 systematic review compared different exercise interventions using a technique called meta-regression. And they found when they compared these that exercise programs that conducted more than 3 hours of exercise a week and contained a high challenge to balance reduced the rate of falls by 39%. So let's take a minute and talk a little bit about balance. What exactly is that? Well, put simply, balance is the ability to stay upright and steady while in movement such as running or walking, as well as when stationary, when we're both standing and sitting. So as such, balance is critical for daily activity and ultimately for preventing falls. Every activity you see pictured here is an example of an activity which requires us to keep our balance. Technically speaking, balance is defined as the ability to maintain the center of mass over the base of support. And what we mean by this is that the center of mass refers to the point at the center of the body's total mass position, and the base of support refers to the area of the body that is in contact with the support surface. So if your center of mass falls within the area defined by your base of support, we would say that you are in balance or you're maintaining your balance. But if that center of mass moves outside of the base of support, that would be a definition of when you are falling, and it's your ability to recover and move that center of mass back in your base of support that determines whether you fall and meet our definition of a fall, or you recover your balance and carry on with the rest of your day. So the analyses that we have around fall prevention exercise from these systematic reviews are important because they provide us with key information that can guide what we need to be doing to prevent falls through exercise. These are called evidence-based recommendations. And in our case, the systematic review from Sherrington and colleagues gave us 3 key recommendations for action. That fall prevention exercise should aim to provide a high challenge to balance, that at least 3 hours of exercise should be conducted per week, and that ongoing participation in exercise is necessary or the benefits will be lost. These are some of the keys that we need to prevent falls. And so I think it's important to pause and discuss these recommendations for a minute because they are really important. First, what does a high challenge to balance even mean? This is a tricky one because we don't regularly measure or compare balance challenge with as good ways as we do with cardiovascular exercise or strength exercise. So generally speaking, balance tasks are made more challenging in a number of ways. First, we can reduce the base of support, so making that base of support more narrow, such as standing in a narrow position or going from 2 feet to 1 foot standing. We can also increase balance challenge by moving our center of mass towards the edge of that, where that base of support is based, and practicing controlling our body position. And thirdly, we can also make balance more challenging by standing without using arms for support. But what is important to remember is that what is challenging for one person isn't necessarily challenging for another person. And so at the bare minimum, I tend to say that if you're doing an activity and you're not thinking about needing to keep your balance and you're not actively sort of focusing on your balance, it's probably not challenging your balance skill. Our second recommendation focuses on time of exercise, that we need 3 hours of exercise per week for the accumulated benefits of fall prevention to add up. And also our third recommendation, that this ongoing participation in exercise needs to happen or the benefits will be lost. So again, just like other aspects of exercise, the concept of use it or lose it applies here as well. So these are some of the what's about fall prevention exercise that we know works. What should we be doing? And now we're going to turn our attention to the how. Many delivery models have been employed for fall prevention exercise. So things like home-based exercise programs, one-on-one balance assessment and training with physical therapists, as well as group-based exercise. Of the many potential options out there, we have been interested in group-based exercise programs in community settings for a number of reasons. Group-delivered programs in community settings can be often more easily accessible and have the potential of influencing older adults' health on a widespread scale. They can also provide social interaction for older adults, which can help reduce social isolation and feelings of loneliness, as well as act as a significant predictor of exercise adherence, meaning that people may be more likely to stick with the behavior and continue it in an ongoing fashion. So as such, we've been interested in community-based exercise programs as a potential implementation strategy for group-delivered balance exercise, and that we think warrant more attention. So again, these are programs that are intended to promote the health and well-being of their members. They can be publicly or privately funded, often delivered by fitness instructors who have received specific training. Most of these programs involve group task-oriented type of exercises and often take place in community centers, usually run by nonprofit organizations like the YMCA or municipal recreation divisions, typically sort of outside of the traditional healthcare system. So for all these reasons, we see lots of potential in community exercise programs. And if they are including the components of effective fall prevention exercise in their programs, they could influence falls avoidance in a wide range of community dwelling older adults. But surprisingly, we actually know very little about what is happening day to day in these community exercise programs. Back in 2010, a Canadian report identified 282 fall prevention initiatives across Canada, 205 of which reported including exercise. This was a report by the Public Health Agency of Canada, and while it gave us a great snapshot, unfortunately, it didn't give us with much detail regarding the nature of these exercise interventions. What were their program delivery characteristics, how often were they occurring, and what types of exercise were they doing within them. And so our group just started to dive into exploring community exercise programs for older adults a little bit deeper several years ago now, wanting to better understand if and how the existing programs that we have are including balanced exercise and effective fall prevention interventions. It might sound simple, but actually identifying community programs across Canada and developing a questionnaire and methods for accurately getting the information that we wanted to out of them was actually quite tricky. So we started out with a small study of older adult exercise programs in Winnipeg, where we are based, to start learning about program delivery, exercise content, and assessment characteristics. Our initial Winnipeg study found that most general exercise programs for older adults did not explicitly focus on fall prevention, and accordingly didn't include all exercise of the recommendations. So this gave us some important information and insight about how to study this concept. But because the scope of our initial work was limited to just one Canadian city and our sample size was quite small, what we really wanted to do next was to be able to have a much clearer national picture of the current state of fall prevention community exercise programs in Canada. Then, fortunately for me, a bright and motivated, interested student came along looking for a master's project to focus on in community health sciences here at the University of Manitoba. And I was very fortunate to have Alexi take over this work, and I'll pass it back to her now to explain what she did.
Great, thanks, Kate. So as mentioned, I met Dr. Sibley a few years ago when I was looking for a project for my master's degree. I had just finished my honors in psychology, and I was really interested in wanting to improve physical and cognitive health of the population by using knowledge and evidence from research. However, a first step to implementation of knowledge is understanding the current state of practice and identifying opportunities for improvement. So as Dr. Sibley mentioned, we became interested in widening the scope of the initial Winnipeg study, and this aligned well with my interests and goals. So that leads us to the specific objectives of this study that we conducted. So the aim of the project was to describe program characteristics and fall prevention community exercise programs for adults aged 50 years and older in Canada, and to determine whether they include the evidence-based exercise recommendations for fall prevention that Dr. Sibley talked about earlier. In terms of participants, instructors of Canadian group exercise programs were eligible for the study if they targeted community-dwelling older adults, took place within the community, and were specified that fall prevention or balance training was a primary goal. The minimum program age of 50 years was established to include programs with a broader concept of older adults. And potential participants were identified either directly from a multi-phase online search or indirectly through referrals from related contacts, such as program coordinators, who were also identified through the online search. Specifically, the multi-phase online search consisted in part of conducting a search of each Canadian province and territory regional health authority, as well as conducting a thorough Google search for each province and territory with keywords such as fall prevention and exercise classes. This identified potentially eligible programs, which were then manually reviewed to ensure that the programs met the inclusion criteria of the study. If the programs seemed to meet the eligibility criteria, we included the contact information of the instructor or the program coordinator, whichever was available. Data collection occurred between May 2019 and July 2019. A modified Dillman recruitment approach was used to contact potentially eligible participants and the related contacts. So this included 4 contact attempts over the course of 4 weeks. So we started off with a pre-notice email, which explained what would happen. Then we distributed the questionnaire sent a week after the pre-notice, and a follow-up reminder was sent to non-responders every week for 2 consecutive weeks. The electronic questionnaire that we developed was adapted from the previous Winnipeg study, and questions were informed by aspects of the fundamental principles of exercise design, or the FIT principle, for frequency, intensity, time, and type. The questionnaire was piloted through an iterative process in which each participant received an updated version of the questionnaire based on previous feedback, and this was done with 14 participants from 5 Canadian provinces. The final questionnaire contained 5 sections with open and closed-ended questions that explored program design, such as frequency, duration, and length of classes, as well as balance challenge, whether instructors prescribed and provided home exercises and resources. We also explored exercise content. So for this, instructors were provided with a list of balance, walking, and strength exercises, and they were asked to indicate whether they conducted the exercises, and if so, whether they were performed with or without arm support. The questionnaire also explored program target population, as well as inclusion-exclusion criteria, and program and instructor demographic information. So here we asked questions regarding the program location, the instructor title or role, their educational background, as well as whether they had received any training in falls prevention and their years of experience. Of note, the questionnaire and all communications with participants were available in both official Canadian languages, that's to say English and French. Open-ended questions and other response options were reviewed and coded into categories when appropriate. Questionnaire variables were used either directly or indirectly through the creation of derived variables to determine whether the programs included the 3 exercise recommendations. Specifically, we coded the recommendation variables into dichotomous variables, and the inclusion of each was defined as conducting a total of at least 3 hours of exercise per week, prescribing mostly, so 50% or more, moderate to high balance challenge exercises, and being offered on an ongoing basis, that's to say offered continually throughout the year with no restrictions on number of times an individual could register for the program. To determine challenge level, the balance and walking exercises were assigned a balance challenge score based on a previous coding scheme. This coding scheme was developed in the context of the initial Winnipeg study by Dr. Sibley and her colleagues, and the coding scheme is based on the evidence-based practice recommendations and used a 5-point summary score based on arm challenge, where 0 points were assigned when the exercise was done while supported, and 1 point was given when unsupported. Points were also assigned for base of support and center of mass challenge, where 0 points were assigned for minimal challenge, 1 point for some challenge, and 2 points for significant challenge. A total challenge score less than or equal to 1 was considered a low challenge. Scores of 2 or 3 were considered moderate challenge, and scores of 4 or greater were considered high challenge. I'll just spend a few minutes giving a couple examples of how this was done. So the balance exercise of basic standing in a comfortable position was coded as a 0 if it was done with arm support, and as a 1 if it was done without arm support. However, the balance exercise of standing in a narrow stance was coded as a 1 if it was done with arm support, and as a 2 if it was done without arm support for the increased base of support challenge. Another example of a more moderately challenging exercise, we have hip or ankle strategy with weight shifts. And so these exercises were coded as 2 if done with arm support, and as a 3 if done without arm support. Examples of coded high challenge exercises were walking and changing directions, which we defined as a turn of more than 45 degrees, and walking with frequent starts and stops. These walking exercises were given a score of 4 when done with arm support, and as a 5 when done without arm support. All that to say that the balance and walking exercises were coded for balance challenge level, and the codes were used to determine whether the prescribed exercises were mostly of a moderate to high challenge to balance. Now we'll discuss the result. So analysis was conducted on 140 questionnaires, with the majority of programs in our sample offered in Ontario and in an urban setting. Based on participant responses, nearly 60% of programs offered classes twice a week and for 1 hour per class, but you can see that there is a distribution here as well. Most participants reported that exercises became more challenging over time and that options were provided to make exercises more or less challenging. In terms of the inclusion of evidence-based recommendations, based on the results from the coded exercises and the derived variables, almost all programs prescribed mostly moderate or high challenge balance exercises. Regarding the time recommendation, just over 10% of programs reported conducting 3 or more hours of exercise per week. But based on a stricter interpretation of the recommendation, for which we looked at total balance exercise time per week rather than just general exercise time per week, only one program included 3 hours per week focused on balance exercises. Based on responses, less than half of programs included the recommendation of being offered on an ongoing basis with no restriction on individual registration. Among the 140 completed questionnaires, more than half of programs included only one of the 3 recommendations. 55 programs included only 2 recommendations, regardless of which 2. 8 programs included all 3, and 3 programs included none. To our knowledge, this was the first national investigation of existing fall prevention community exercise programs for older adults. An important finding was the varied distribution of evidence-based exercise recommendations in the represented programs, where virtually all programs included moderate or high challenge to balance. Just over 10% of programs included the recommended 3 hours of exercise per week, and just less than half of programs were offered on an ongoing basis. Based on the results from this study, group exercise programs aren't including all of the recommendations. At the time we ended the study, we recommended mixed strategies as a way of meeting the targets, such as a combination of in-person and home-based exercise strategies. However, obviously with COVID restrictions, having in-person group exercise classes is not happening in many places right now in Canada, and we'll revisit this in a few minutes. However, in the pre-COVID context and in the eventual post-COVID context, there are many factors that may be influencing whether community exercise classes are including the evidence-based recommendations. Commonly cited organizational barriers to providing evidence-based practice in the literature include a lack of available and appropriate community venues, the number of full-time staff, funding, and availability of tools and equipment. Therefore, including all of the recommendations may not be feasible for in-class exercise programs alone. Although the study did not examine program planning and decision considerations, future research should explore personal, organizational, and systemic barriers to including the recommendations. Future work should also explore program decision-making factors and should consider collaborating with program coordinators to explore potential options for sustained delivery. There are just a few limitations of the study worth mentioning. So first, this was a self-report survey study, and although efforts were made to identify as many potentially eligible fall prevention community programs as possible through the online searches and through snowball sampling, it's important to note that the total number of instructors or programs in Canada is not known, as there may be programs that don't have an online presence or are only offered through referrals. Furthermore, although most provinces were represented in this study, we did not receive any responses from the 3 territories and from 2 provinces as well. The study provides insight into design characteristics of fall prevention community exercise programs in Canada. Based on the results from the study, community group exercise programs aren't including all of the recommendations. This finding highlights the need for mixed strategies to encourage and provide effective and safe evidence-based exercises for fall prevention for older adults living in the community. Before we get into the discussion surrounding these findings in the context of the impact of the novel coronavirus, I would just like to acknowledge that the study was funded in part by the Canada Research Chairs Program through Dr. Sibley's Canada Research Chair in Integrated Knowledge Translation in Rehab Sciences, and through a couple scholarships that I received as a master's student. I would also like to thank my committee members, Dr. Allison Oates from the University of Saskatchewan and Dr. Verena Menick from the University of Manitoba for their help in this project. I'd also like to thank everyone who participated in this study, as well as everyone who helped facilitate the recruitment. So, like many things right now, group exercises may need to adapt in order to provide safe options to continue exercising, and we recognize that many of you are already adapting to the current context. Here, I'll pass it over to Dr. Sibley to discuss other options in further detail.
Thanks, Alexi. That was an excellent summary of your study. And again, I will remind our audience that if you are interested in the full details of this project, that Alexi's paper has just recently been published. It's open access, so that means that anyone can read this paper. It's not behind an academic firewall. So it's published in BMC Geriatrics. If you search Alexi's last name, it's quite easily found. And I also just tweeted a link if you're on Twitter as well. So before we take questions and open things up for discussion, we wanted to spend a few minutes addressing the proverbial elephant in the room right now, that is COVID-19. And so as Alexi discussed, when her study concluded in 2019, we knew that next steps would be to examine barriers and facilitators to implementing these exercise recommendations. And as Alexi discussed, we felt that likely a probable feasible way of moving forward would be that hybrid models that supplement the community group exercise setting with home-based exercise would likely be the most feasible option for many programs. Now we have the pendulum that swung the entire other way. And with COVID, we find ourselves largely unable to meet in group settings at all and relying almost totally on home exercise. So whether we're thinking about pandemic fall prevention, exercise home delivery models, or a post-COVID hybrid type of community and home-based model to meet these exercise recommendations, what do we need to be thinking about? I certainly don't have all the answers here today, and many of you who are working directly in this area likely have more experience than I do. But I wanted to spend a few minutes talking about some of the things that we should be sort of considering and problem solving together. And so when thinking about home-based fall prevention exercise to supplement community-based programs, I think we can think about three main areas: safety, effectiveness, and rollout. And yes, if this sounds very familiar, like a vaccination program, which we might also be talking about a lot these days, you're very correct that this is where I drew inspiration from. So safety is clearly top of mind and something we hear concerns a lot about, and understandably so. But I think there are lots of things that we can be doing to promote safety in fall prevention exercise at home. We want to be doing things like making sure that our exercise space is clear of hazards, that we're exercising in an area where you have support available, or an extra chair beside you, exercising beside a kitchen counter, doing things like if you live with someone, having them available nearby the first few times you are doing a particular exercise, as well as having phones in reach for emergencies. Then we have effectiveness, which brings us back to our recommendations. And here I think there are a lot of creative ideas we can be doing to promote the 3 hours a week of exercise and promoting exercising on an ongoing basis. Though these can be largely things around what can we be doing around accountability and motivation, how can we be checking in with our clients, maybe through a calendar and tracking type activities, things like small contests or incentives that we might provide to continue exercising. In this case, I think around the effectiveness piece, the balance challenge issue is the one that's going to be the trickiest. And I can understand the temptation to prescribe less challenging exercise in priority of safety, which we just talked about. And that's a hard one. I think in any exercise, there is risk involved. But practitioners tend to feel the tension between safety and effectiveness in fall prevention exercise very strongly. And I really get that. So obviously every client is different, but my recommendation is to try and find the combination of balance and fall prevention exercise that you and your clients are most comfortable with. And so my concern is always that if we avoid challenging balance exercise at home in priority of safety, but then our clients head outside for a walk and fall when they can't catch their balance on their front steps, where has that left us? And that's absolutely a challenge and a tension that we all have to manage. And so for those who decide that challenging balance exercise isn't worth that risk right now, I think that's also okay. But then what we need to understand is we're not necessarily meeting the objectives of a fall prevention exercise. What we're talking then is about physical activity, movement, and exercise for other goals, potentially strength or mobility, cardiovascular conditioning, or even just movement or social benefits, which are all good things and reasons to keep moving. But if it's not effective, we cannot be claiming that it will be helpful and effective for helping older adults avoid falls. So then lastly, we have our rollout, which if we stick with a vaccine analogy, proves to be no small task in and of itself. There are lots of considerations here as well, such as what are the technology requirements necessary for engaging at home? If we're using technology, do we stick with recorded options available through an internet or something like a video or a DVD? Are we doing live sessions? There are many online options available, but we might also need to be considering options for those without good technology access and all the reasons that might go into that. We may be needing to provide our clients with instructions for connecting. It could be step-by-step, tech support as well. Having an extra person close by when we're offering programs to be responsible for tech support, just like we're doing here in our webinar today. We also need to be thinking about what types of equipment our clients might have access to in their home settings, which will of course determine what we're able to do in the program as well. And of course, we need to consider the costs associated with all of these, both as costs to the programs themselves, but also what costs are associated for our clients. And I think lastly, bringing the conversation full circle back to why we were interested in community exercise programs to begin with, what kinds of community can be built when we are physically distanced? This could include incorporating things in home exercise like virtual gatherings or phone calls, potentially small socially distanced outdoor meetings if your weather and government conditions allow that. These could all be important for providing us with opportunities for social interactions, but also allow instructors to check in and monitor progress and potentially giving cues or asking them more information about the difficulty of the exercises that they're working through. We could use it to provide additional instructions and answer questions about the exercise programs as well. So as we said, these are just a few of our ideas on considerations for how to be adapting to programs to meet the evidence-based recommendations and how to continue being physically active right now. Obviously, we're all looking forward to the day when we can get back to our community-based group in-person sessions. And I think Alexi's study has provided us with some really good insights about where our strengths are and where we can be continuing to look to support programs out there to have the most effective prevention programs for older adults. So with that, we're going to wrap it up here. I'd like to thank again the Loop community for inviting us to present and for all of you for joining today. And we're very happy to open it up now for questions or comments at this time. So I think Alexi, I'll turn it back to you at this point.
Sure. So then Shamiza, I go into the Q&A box, right?
Yeah, but before you do that, I just wanted to thank you both for, this really wonderful presentation, for sharing your extensive knowledge of fall prevention community exercise programs for older adults, but also addressing, the context, our current context of, pandemic limitations. So thank you very much for that. We did have, as you mentioned, have a few participants who submitted their questions in the Q&A box. So I'd ask you now to just open that up, and we can kind of go one by one through them. And as you do so, participants, I do encourage you all to, if you have any questions for Dr. Sibley or Alexi, please type them into the Q&A box now, as we're going to now begin the Q&A session.
All right, so I'll just start reading the questions one by one. So we had one question: is there a listing of various exercises and their balance score available? Kate, do you know if that was ever published anywhere?
Sorry, just going on mute. Yeah, so a couple of places you can find that. So yeah, we had to sort of divert a little bit. The balance challenge coding exercises has turned into little sets of mini projects throughout the way as well. So the short answer is certainly the exercises that we asked about are published both in Alexi's survey, as well as the sets of exercise that we asked about in our first project in the 2019 paper, so we can get you references for both. We do not have a publicly available sort of set of codes for the exercises so far. That's certainly something that we can look into if that would be helpful to people.
Then we have a next question. How many people were in the study? There were 140 participants that completed the questionnaire that were included in the analysis. Next question, are facilities such as assisted living programs considered community? They were not considered community for the purpose of this study. And then we have a bigger question here, so I'll just read the whole comment. I look forward to reading the entire study following the webinar. You talk about balance exercises in terms of exercises or stances, movements that challenge balance, but to reduce the risk of falls, it's important to make an impact on the causes of falls. For example, Mary is sitting in a chair. Her phone rings, and when she gets up to answer the phone, she falls. Would you agree that Mary would reap more benefit from strengthening exercises, such as sit to stands, helping her get out of the chair, toe lifts as to not catch her toe and trip while walking, coordination and agility exercises? It's great you are looking at balance exercise, but future studies could benefit from looking at exercises that make an impact on reasons why an older adult falls in the first place. If we stand on one foot every day, we would likely get better at standing on one foot, but it would likely not prevent falls in Mary's scenario above. That's a great comment, and I do believe that, pardon me, in Sherrington and colleagues' recommendations, they do recommend strength exercises as well, but not necessarily just to prevent falls, but to help strengthen the muscles used to prevent falls as well. So it's a very good, very great comment. I don't know if Kate, do you have anything to add to that?
Yeah, agree. Thank you, Emily. You could help us write some case examples. I will have to tap you for that anytime. The issue of strength and balance as one or the other or distinct, I think, is a common question that we get. And certainly there is a lot of shared components within them. The sit to stand exercise that you referenced for a second, is an interesting one that we have a debate about all the time. Because if you were to go back specifically and look at the development of the sit to stand test that you might be familiar with, it was originally developed as an assessment of strength. And then sort of over time, it certainly became recognized that there was also a very significant balance challenge associated with the movement of the center of mass in order to perform the sit to stand assessment. So for many of these exercises, while we have focused on the balance challenge component to them, there's certainly absolutely an element of strength in there as well. And if I'm interpreting the toe lifts, that you mentioned in the same way that I might interpret a toe lift or like rise to toes type of exercise. Again, there's going to be certainly a significant body weight challenge associated with lifting the whole body up, as well as a significant balance challenge associated with the reduction in the base of support from standing on your full foot going from up to your toes. And if you could see me right now, you'd see all the actions that I'm doing to sort of mimic this. And so again, I wouldn't say that it's a better in this case of one versus another. I think all of those exercises would be fantastic. And certainly we showed some very simple examples here as well. I agree. If all you're doing is standing on one leg, while that might be somewhat of a balance challenge to that, that's not necessarily in and of itself going to be the only exercise that is appropriate or effective at reducing falls. The issue, and I think the teasing out component that we're trying to do in the literature and when we're doing this analysis, is if your strength exercise is sort of purely, if there is no balance challenge in your exercise that also requires strength, then that is not going to be an effective fall prevention exercise. And so if we think about some of our simplest, like a sitting and putting like weights on your ankles and doing like a knee extension, for example, you will build strength. That strength, if that's all you're doing, you're not going to be having the balance challenge and necessary to reduce falls. And so that's sort of like, if we think about the compendium of all possible exercises, what we're trying to sort of nudge folks for. So that's a long answer, but I hope that helps.
The next question, do you have any recommendations regarding functional balance assessments? We tend to use the Berg balance scale, which after several years of using this, I find it addresses the strength and ROM issues of balance, but CNS not so much. Kate, did you want to address this question?
Sure, thanks, Karen. I could do a whole nother talk on assessments for balance and mobility. We do have some good suggestions for that. The Berg is great. Lots of people are familiar with it and comfortable with it, so that's great from an implementation perspective. We tend to focus and recommend the suite of assessments that address some important balance components not addressed in the Berg. And so that's the balance evaluation system set of tests, or the BEST tests that many of you might be familiar with. And there are 3 versions of this test. There's a very long comprehensive version, the full BEST test, as well as 2 shorter versions of this BEST test. The mini BEST test, which has 14 items, and the brief BEST test, which has like 6 or 7 or something like that. And we've done a lot of complementary work related to Alexi stuff around some of these tests. And so I'd be happy to chat offline more about those. But if you're not familiar with the balance evaluation systems types of tests, those are what we recommend.
Great. And then we have a question from Lori. Can you provide a list of exercise programs which are recommended based on your balancing scoring criteria? Don't believe we looked at that. Like we didn't, we don't have any recommended programs that we concluded or anything yet. But there are some evidence-based programs out there depending on the province that you're in. So I would just suggest looking through Google to make sure that you can find some programs and maybe even contact the program coordinator to talk to them about what they offer in their classes and how they challenge balance.
That's a great question, though, an idea. And so from our perspective, from a research perspective, that's an ethics issue in terms of our ability to maintain the anonymity of the participants. That would be interesting, though, to go back to participants and explore their interest in being highlighted based on their analyses. But that certainly was not the intention at the time for the use of the data.
Question from Robert. You said the big meta-analysis study showed that 3 components, 3 hours, high challenged balance, and ongoing were necessary. I missed the results, benefits of meeting these. So I'll just go back to the slide. This is the study that highlighted those recommendations. And they found that having those 3 components reduced the rate of falls by 39%. And so next question, is there one particular program that really stood out as a model that you could share its design with us? Unfortunately, like Kate mentioned, because of the anonymity of our participants, we can't really do that, but that would be really cool to be able to talk with the programs and see if they're willing to be highlighted. Is there any other province beside Ontario that funds free exercise classes for older adults? I'm not too sure about this question. We didn't ask about funding in the survey. So within the context of our study, I'm not sure I could answer that question, unfortunately. Will you email out the exercises recommended? That's a good question. In the study, in our published study, I did provide the link to Shamiza, so I think that'll be provided to everyone here. There will be that list of exercises that were done by most programs, and they do have their challenge score written beside them. So that can kind of give you an idea of which exercises are scored less challenging and which are scored a little bit more challenging. But as I mentioned, the walking exercises of the frequent stops and starts, that was coded as a high challenge exercise. So anything that's really challenging the base of support, the arm support, and the center of mass challenge as well. About how long would you spend on each individual balance exercise to get full benefit of the exercise if using stations? Kate, do you want to comment on this? I'm not sure.
I don't think so. Based on our study, I don't know that we have we would not have that data based on our study. And certainly, again, I think that's a great question, and that points to how this area is actually like difficult to study and document compared to others. So really all we have now from an evidence perspective to guide our prescription is that that total time, right? And so it would be up to you within that to sort of figure out. And so certainly what this series of studies that we've done is highlighted where there are gaps in our prescription guidance. So we don't unfortunately have that information yet. So if others have typical recommendations that they use, I'd love to please put them in the chat. Maybe we can have some shared discussion going.
Another question, did you review the training and competencies of exercise class instructors? So we did. That was one of our questions we asked, what's your educational background? What's your title or role? And we found that there was a wide range of educational backgrounds, with the majority reported receiving training in falls prevention in general, and that most instructors reported having 4 or more years of experience in their role, and that the program was delivered by a certified fitness professional or a health professional. And so more detail on that can be found in the study if you're more interested and want to read everything in detail there. And can you recommend any specific discrete exercise videos that PTs, OTs, and public practice can send to clients as individual exercises as part of tailored exercise prescription? So I think based on the study, we can't answer that, but there are, if you look at provinces and Google exercise classes, things like that, there are a lot of programs that have been transitioning to the online model.
Yeah, I think we, in doing some preparation, I think Alexi, the TIME program, do you want to talk about that and their resources?
Yeah, so one program that together in movement and exercise, or time, they're providing quite a bit of resources on home exercises. And so they have a list of resources like general information, but they also have some videos for exercises, and that's ranging from gentle exercises, stretching, all the way to balance exercises specifically. So that could be a resource if you want to look at different types of exercises. Were there any evidence-based or standardized programs included in your study, or were they personalized instructor-developed programs? Those are a little bit of both. Why was intensity of programming a key barrier to meeting recommendations, i.e. less than 3 hours per week, community program funding? Okay, so we didn't look at the barriers in the study and in the survey, but there are quite a few barriers highlighted in the literature. So we can only assume that some of these barriers would be having an effect. So some commonly cited in the literature are just lack of available and appropriate venues, lack of funding and full-time staff, as well as just lack of equipment and yeah. That question. Just some comments. I work in adult ABI and often use senior-based resources as not much specific to this group. May want to consider that your education can reach a broader group. Also, would be nice for government to support more ways to support prevention, i.e. fitness tax credit for older adults or technology tax credit. Another comment, even before the pandemic, it was difficult to have patients complete 3 hours of traditional exercise a week in a home environment. Have there been any studies looking at combination of daily activities that would count as an exercise combined with a couple of balance exercises that would make up 3 hours of exercise per week? I'm not sure I've ever, that's a great comment or question. I'm not sure I've ever read anything about.
Yeah, there is. So there is a program that originated in New Zealand called the Lifestyle Integrated Functional Exercise Program, I want to say. The LIFE program is the acronym for it. And I believe the lead author is Lindy Clemson. And so there is a program that has been and so that's exactly its intention, is to integrate exercise throughout one's daily life as opposed to sort of traditional exercise bout. And that would be another great thing to integrate. And so I think sort of what is interesting and unique about this set of work that we're doing is that we have examples of evidence-based programs out there. So like this LIFE program would be one, or you might be familiar with Otago or Falls Proof, active aging group in the UK. There are several examples of fall prevention sort of programs, right? But these exercise recommendations that we have look across, from Sherrington's group, look across all of the programs to try to identify what are those components, right? And then what we did in this community-based study was to explore whether you are using a preset program or not, which I think, realistically in a community settings, most of them were probably not using a preset program. What were they sort of getting at? So I think the good thing is there are lots of like potential options moving forward to really try to target that amount. And I have to say, like, I was surprised that it was the 3 hour recommendation that was the one that was the least commonly incorporated. My bias was towards the challenge level of the exercise. I always sort of was concerned that we may not be challenging enough. We still don't know that for sure because it's a self-report study. All we can go on is what instructors told us. But I think the good thing is the 3 hour piece is there's lots that we can sort of be drawing from in our next steps to help push that forward.
Okay, great. So it's me again, Shmiza. Thanks, Kate and Alexi, for answering all of those questions. We do have a few more remaining, but unfortunately, we are out of time. So perhaps I'll work with Alexi just after the webinar to just send some responses out to the individuals that had a few questions. Would that be okay with you, Alexi?
Yes.
Just a few more. I don't think there are many more.
Yeah, that's definitely okay with me.
Awesome. So I will be in touch with respect to that. But in the interim, thanks for all of our participants for joining us today and engaging in such a great discussion. And thank you again, Dr. Sibley and Alexi, for volunteering your time to do our Loop presentation. So just in terms of just some wrapping up items, for more information about the fall prevention community of practice, you can visit Loop at fallsloop.com. And when the webinar has ended, you'll be redirected to Zoom and you'll be invited to participate in just a very brief evaluation survey. You just have to click the blue continue button on your browser and then you'll be redirected to the survey. And as always, we appreciate all of your feedback so we can continue offering webinars in the future. So that brings us to the end. Thank you all and hope you all have such a wonderful January. Take care. Bye.